In any enterprise, best practice is about meeting the client's needs. And for today's workshop, Te sponsored and developed You're the Clients. And so this session ultimately has to be the best practice session where you've heard the evangelists, but what are your needs? What questions do you have? And this is the chance for you to control the agenda. And I would ask the panellists to be very brief and succinct and relevant when they answer all these things, and they don't take any questions as an excuse to give a new lecture. You've already met some of the panellists. Tom, you've met. Barry Welsh was sort of referred to earlier this morning, and that's him, the second one. Fiona, you've met. You haven't met somebody who you might think from the program runs a scaffolding company, but can you just maybe say 20 or 30 seconds worth of who you are and what your expertise and interest is and what Platform Trust is, so people, Marion, please, so that people have a rough idea what sort of questions they might expect you to answer.
Hi everyone, my name is Marion Blake. I'm the CEO of the Platform Trust, which is a national network of NGO organisations that provide a whole range of community supports across New Zealand.
Thanks, Marion. And then Alan, he will explain to you what you might have picked up in the session after lunch, that in fact Wild Bamboo isn't that restaurant down by the railway station, but Alan, can you just say something about yourself and Bamboo?
Yes, look, certainly, Alan Grainer. I've got one job, two roles. So I'm the CE of Wild Bamboo, which some of you will know. It's a specialist software company providing a client management system, and I also double as the CIO for the WISE Group, of which Pathways is one of the entities. That's all since December. Before that, I was at Waikato DHB as the CIO.
Thank you. Now, is the sound working all right with their mouths that close to the speakers? Can anybody tell me, or do they need to make their mouths closer? Is that okay? Yeah, you need to, please, panel, when you answer the questions, act like pop stars like that, the penultimate speaker was interested in.
Another question for Tom, just to say, you talked about HONOS as one in a range of outcome measures. Do you want to say a little bit about a number of other outcome measures that you would recommend to use in mental health services without having to read your book?
I just stole my answer. Well, there's too many to list, but I think the categories of outcome measure are measures of illness severity, which HONOS is the leading one. There's measures of disability, and I think in Australia we use the life skills profile, and I think that was trialled in the CHAOS study 10 years ago, and I think there's one or two others. There's quality of life measures. There's measures of need, specifically of need. I don't think high scores on symptoms necessarily reflect need, but the one I'm familiar with is the Camberwell assessment of need, which is used in a number of countries. And then there's recovery measures, which are the most recent entrant into the field. Now, I think within each of those categories there's a number of measures. And some of those measures are completed by the provider, and some of them are completed by the service user. And some of them, like the Campbell assessment need, can be completed by both, which is actually a very, very nifty thing, because then you can actually compare like with like. So those would be the domains, the main domains of measures. And I think the HONOS, which is used here, is one member of one domain. Whether one is enough or whether you need to use several in order to capture different things that you're interested in. You said, which ones would I recommend? It depends what you're trying to do. There's a wide range. There's a wide range of choice, but which ones you pick depends upon what you want to know.
I think it might be helpful whether the Ministry of Health has a response to that question or a view on it. Barry, put your mouth close.
Absolutely. I mean, I think outcome measures are significantly important in this. The Ministry of Health absolutely believes in outcome measures and being able to demonstrate improvements for clients, and there's many ways to do that. At the moment, we're focused, as you know, on the HONOS outcome score, but there is a need for consumer rated tools. We've been through quite a process in New Zealand at developing a consumer outcome tool that probably didn't fulfil all the needs that a nationally collected outcome tool would be, but we're certainly still interested in that and believe that it's really very important, but we're focusing on one thing at a time at the moment.
Please.
This is probably a question that Marion might be best placed to answer in the first instance. And I wonder, Marion, if you could give us your thoughts on, given we've got one unique measure within DHB clinical provided services, whether or not across a spectrum of NGO provided services there should also be one unique measure being used, or whether you think there's value in NGOs continuing to innovate and use measures according to what they are after.
Yeah, thanks, Ross. This was obviously really well traversed across the NGO sector when the suite of outcome measures was being discussed. However many years ago that was, Barry?
10.
Yeah, and it ended up that NGOs, the only data collection obviously was the prime data collection. And what's actually happened is instead of having one data collection set, we've got this rich tapestry of kind of places of different tools emerging for different situations. And whilst that makes measuring apples and apples quite difficult, actually we're not dealing with apples, because one of the real challenges is that community organisations are doing a whole range of stuff, from supporting people in crisis through to providing employment support, etc. So to go down one line of having one outcome tool, I think was, in retrospect, very lucky that we didn't go there. However, I do think that our challenges are now is actually getting outcome tools that are useful for the environment we're working in. We're still collecting, our focus is on clinical outcomes most of the time. In actual fact, most people, the most important things are, as you, I think, referred to in your presentation, is a sort of a house, a job and relationships. We're not measuring those things, we're not measuring them well, but in actual fact we need to. Just going back to what Ashley was talking about this morning, the crisis that we've got in the country, it's always referred to as a burning platform, and as the name of our organisation is Platform, it's always quite an uncomfortable place to be. But actually, those people on that they were talking about in relation to the better public services and the need to increase or decrease the number on welfare dependency, those are mental health people. And those are the clients that we're talking about. Something 75% of those people are also living with a mental illness. So if we don't think about how we're going to measure some of those things in a mental health worldview, then we're missing the boat completely. That's the short answer.
Yeah, I could just refer to some of the history, because just before the Boer War, when all of this talk in New Zealand was started about outcomes, in fact, the line that Marion is taking was very much put forward, but there was some very significant I shouldn't say dictatorial, but ultimately decision from the Ministry of Health to concentrate on the one or a limited number. And I think that Tom's answer to that earlier question of Helen's about horses for courses is starting to emerge just by the natural evolution that it has to be like that. Other questions?
Please, Graham.
Yeah, call for the microphone, please, Mike. Oh, you've got one.
Could I just ask, this maybe for Tom or perhaps Graham, maybe Barry. Currently we're focusing on the HONOS family of measures. Can we say with assurance that these are fit for clinical purpose, i.e. that it's okay for clinical services to be using them?
Well, it's a very clear question, but it's actually very, very difficult to give a definitive answer. I think the HONOS is good for measuring what the HONOS measures. And the question is what the HONOS measures everything that you need to know? In Australia, we have definitely gone down the path of a suite of measures. Almost at the very beginning, we thought there was not and could not be one measure, unless it was extremely long, that could assess everything that we ever needed to know. And we, in the end, decided on a severity measure, which was one of the HONOSs, a functioning measure, which was the LSP, and a self-report measure, which we don't have national consistency, but every state is supposed to collect something from the client. So used by itself with nothing else, it probably doesn't capture as much of what most people need to know. What else you need to have with it is a question for local determination. Partly what, like I said before, what do you want to know? And how much money you're prepared to spend, and how much time is it going to take for people to actually complete these things and enter them into a system. But I personally think that a single 12-item provider-rated measure of largely symptom severity probably doesn't capture enough of what you need to know to see how the client is going. What the other things would be, I think, is another question.
Tom, you'd have to perhaps accept, though, that the databases in Australia and here used to record only, age, sex and diagnosis. So now we're getting at least a broader description, not exactly a detailed formulation, but we're getting a standardised description which gives more comprehensive information for a start before you get on to talking about the psychometrics, which obviously becomes a big determinant of the proper answer, as Tom has given to Mark's point.
Yes, I'd agree with that. It's better to have something than to have nothing, but I'd also say that more data does not always mean more information, and that it's a question of how much time and effort you're going to spend to collect what extra information you need over and above what you already have, and that's a tricky one.
And I also think, there's we need a multiple range of information. We've just heard from CAM services the use of KPP. So that also supports, a collection of relevant information to improve services and outcomes for clients.
1, 2.
I was interested in the point about more information or more data. Does that give you more information? I mean, this morning we heard Ross talk about, a 31 outcome measure, but he was particularly excited by the 6 outcome measure. Before that, in another presentation, there was sort of a four-point sort of measure, which I got excited by. And that's a lot to do with, I think, respect of when you're interrogating clients about this sort of thing. Treating people as respectfully as possible, sometimes being in their face less is much their desire. I was just sort of wanting the panel's feel on what gains there are from getting more, or are there gains, or is, my desire for 4, if possibly 2 questions, is valid.
Could we perhaps start with Fiona on that one, I think, and then we'll move to...
That's a very good question. I'm excited about 4 measures rather than 90 or completing 3 different questionnaires as well. I'm not quite sure where to begin on that, really. There's a couple of things that have occurred to me from this conversation, so I might just approach that a wee bit tangentially. One is, just wanted to add on the NGO sector. I think it's important to... Our NGO sector in particular is very values-driven. My sense is if you have mission statements and purposes and values that you're putting out there about your practice, that's the type of stuff I think you should be measuring with your service users, whether you're meeting those aims. So that might dictate the kind of measures you would use to some extent, within the domains that you've been talking about, Tom. I think keeping it brief and focused is probably useful. Does that
sort of like,
getting in there?
Are there actually gains of expanding it a whole lot, or do you get it just quickly?
If you're fit for purpose, and I think it's also following on from what Ross and his team, his co-presenters, were saying, that that this is part of the work. I think it's not viewing it as an add-on. With outcomes, I think often we make a lot of assumptions about cause and effect, as David was saying before too. If things don't go too well for the clients, we often tend to blame that on factors to do with the client. They've not been compliant with the treatment, they haven't taken their medication, their lifestyle's unmanageable or whatever it might be. When things go well, we tend to attribute it to the services. So I think regarding outcome measures as an integral part of the work rather than an add-on to the work for me would be the key. This is the work, really. So find a way to do it that is workable for everyone within there.
Right. Any other panellists have a response they'd like to make? Alan, yes.
If I could make an observation, which I think is, I'm anticipating a further question here. So it's an observation about the day thus far. So avoiding the question about 2 and 4 and 6 and so on. And I've been struck by the breadth and diversity of the use of measures and the initiatives and the range of types of practice that have been talked about here today. I think that's impressive, and I'll sort of take that as a position. But the thing that occurred to me a little while ago, and actually was prompted by David Ireland over there, because I inherited this, I got this job and got this product, and was telling him we've got 23 outcome measures, and that's pretty cool. And he said, "Oh, I know there's lots of them, hundreds of them," and it started me thinking about, well, how do you know how many? Is that too many? Is that not enough? That sort of thing. And so where that leads to is this. It struck me that, in fact, we talk about outcome tools and outcome measures, but frequently they're actually forms of assessment. So when we talk about outcomes, we really have to think about the whole process. Here's a measure. There's a whole lot of stuff occurs in between, which may be about practice, service provision, people's lives. People talked about the external factors that go on, and then maybe there's another measure. So really, it seems to me the value of these things that we're talking about here is really looking at the whole process, and it causes services and practitioners to evaluate what they're doing and the effectiveness of that, as much as what happens for any individual service user, consumer, call them what you like. So in a sense, if that is a model that people nod their heads about, then it's less about an interrogation or, sit down in that chair and fess up to what you've done with your life so far, and more about where are we going from here with what we understand about the situation to be. And that certainly came through for me today as well from most speakers, and I wrote things down like need to think about our engagement at an individual and family level. This is about the assessment of change and so on. So we're actually going, I think, in a very useful direction, and the diversity feeds that. That would be my observation.
Does that get you agitated from the Ministry of Health point of view, Barry?
No, not at all. I mean, it's a complex system, and we need to be able to demonstrate, outcomes and use information at a person level, at a service level, and at a national level. So it's complex, and that necessitates a number of measures that we need to use.
I think we'll move on to the other question that was sitting over here, yes.
I want to respond to one or two of the points that have been made recently, particularly the one that was made about the values implicit in measurement. Values are inescapable. Whatever you measure, there is an inescapable and implicit assumption that this is important. And if you measure this or that or something else, then you are saying, well, this is important to measure. Quality of life, and if you measure nothing, that is also a value. So there is no escape from actually saying we think this is important to measure and those things are probably less important, we won't bother with them. So I think the best you can do is say we collectively, after appropriate discussion and consultation and taking everything into account, think it's important to measure this, this and this. These other things are probably important, but we just can't do it. So I think whatever you do or whatever you don't do, there's always going to be values. And the best you can do is just be overt and transparent about them. As to, I think the point that was made earlier on was about, well, which instruments should we use? Should we just rely on HONOS? Do we need HONOS and something else? Should we use long instruments, short instruments? It's easy to get very preoccupied with a kind of, instrument neurosis about, are we using the right one? And, some people somewhere else seem to be having good results with something else, and all of that. I think the better focus is not on the instrument length and the questions, but as to the sources of information. Let's say you could only ask 12 questions. Would you rather have 12 questions answered by a service provider, or 6 questions answered by the service provider and 6 by the service user? I think I'd probably go for the second, even though I got less information from both. I finish up with 12 items of data, but I think I've actually got more information, which is the point I was making before. But I think diversity of source of information is probably more important than the detail that you get from any of them, because it's where you get different stories from different people that you get information that you can use.
Isn't there an element of focusing on what's important, because you can't do everything? So is it worthwhile collecting data on information that you're not going to use again today, and focusing on what's important and following through with that?
Yeah, the trouble is that different people think that different things are important.
But I think your principle, I think, has received support from what David was saying as well. But Marion, you were going to comment as well.
Yeah, I just want to agree with David. If we're not using it, why do it? And we are so good at this in health. We collect all sorts of stuff that we never go anywhere. I think your opening image, Robin, of a black hole is kind of like, it's many people in the room's probably experience, And so I guess the question is, when do we stop doing this? When do we personally take responsibility and say, actually, this isn't going anywhere, it's not improving what we're doing, it's no good for people. So there's something about taking some responsibility and being really clear about what we do and what we do with what we do. One of the things I think that's been really important about sort of today is the utility question. Show staff what that means. Oh my God, do we really do it that way? Are we really not making any difference in that area? Or goodness me, look what we are doing, isn't that fantastic? So there has to be a correlation between collection, utility. And so if it's the 4 questions or 24 questions, I don't think it matters. I think it's actually about putting it to good use.
Same line as Tom's.
Yeah, absolutely. And
as yours, I think.
Going back to this good old burning platform, I think we've really got to get real. We've got a population of 4 million people, not as big as Sydney and a bit bigger than Melbourne. And yet we've got this multiplicity, duplication, waste of time, energy and effort. And on one hand, we've got a government...
You're not talking about the Ministry of Health there.
No, I understand these days they're a lean trim machine. But we've really got to, we're getting productivity chucked at us left, right and centre. That's not going to change. We've got to find a way as health leaders in this field to do something about that, So I'm very keen on kind of like finding some ways of finding what works, do it, and do it once, and then use it.
I absolutely agree with David. Not surprising. We've worked together for 10 years looking at services, and we've got to be able to define the product. What is it we're doing, and did we achieve it? It's really not that complicated. So, but at that level, it's not that complicated. At a system level, we need to be able to justify our existence and be able to report to ministers and governments about what we do and be able to demonstrate change and improvement. And, we can do that a lot better than we could 10 years ago. And it's really quite exciting.
Okay, Helen, you've been waiting patiently.
I've got 2 questions. One is about the role of information technology and perhaps improving the utility of these measures for the individuals who we're working with, and whether Alan particularly thinks there's a role, with apps and other things and doing that, so it doesn't feel such an assessment form-filling process for people. The second thing is I'm having a real worried moment here. I'm thinking of a world where there's wonderful integrated ministerial working across departments, MSD particularly get very excited about the range of assessment tools that the Ministry of Health have in place and start to want to use some of them for other purposes. how are we going to manage the risks associated? How are we going to get our own house in order about because I do think we need to agree which are good measures and which aren't, and also be cautious of when we get into joint working, which ones we use and other people using them for different purposes.
I think, Alan, you better start on that.
Yes, I think I've made quite a few notes during the day, and I think the points that were raised about utility and clinical utility and the ease of data capture are important, and things that certainly in terms of IT and software development we don't always do well. It's in fact, it's perpetually a challenge, and certainly when Ross and Angela and Brian were talking, I was making notes because I'm sure they've already got those things as product enhancement requests, and they've used you as an opportunity to emphasise how soon they want them. So I'll have to go back and check out where those are up to. But I mean, those things are certainly a challenge, and I'd say now, having been on a couple of sides of the product delivery, IT product delivery equation, that certainly having fewer tools will be better, because there's only so far you can spread yourselves, practically speaking, and the expectation level is around IT is very high. Now, it's not a violin session; it's just a statement of the obvious. But there are certainly important utility challenges there.
Fiona?
Yeah, I wouldn't mind a chance to comment on that one too. We've got a droopy microphone here, so just bear with me. Thank you, Marion. We'll get some girl power onto it. I think I'm interested in the second part of your question about the use of tools across different services, and I know even in conversations I've been having recently with primary care providers, talking about interfaces that primary mental health care providers have with secondary care, even in that, across that setting, it's difficult. The languages that we use, the forms, the assessments from secondary can often be seen as far too specialised and technical to apply to primary, and I guess that would be true for a lot of our NGO services as well. And at the risk of getting a telling off from the chair of the panel, I'm going to put another little plug in for the CDOI tools here. What we didn't get to tell you this morning is that they are already being used in many, many different settings across New Zealand and in the States as well, I understand. So, for example, some of the groups that are involved in the New Zealand reference group that Robin has set up, like Methodist Mission in Dunedin, they have definitely several mental health services, but they have other services as well. So they're using the CDOO tools in their education service with 3 and 4-year-old children to see how the services have been going for them, and then also with their family and caregivers. Robin here with Wesley Community Action in Wellington, they've used it in a number of their other services that aren't specifically mental health based as well. So I think the point is a good one. Choose the right tools that we can use with confidence across a number of different social and as well as health settings. And I think